edition of the Elder Shoulder Podcast. With me, I have a very special guest, as always, as usual, but a very special friend of mine who I met in fellowship, Dr. Vahid Entezari. Did I say Entezari right?
That's perfect.
So he's an orthopedic surgeon. He's a shoulder and elbow specialist. He's practicing in Ohio, right?
Yes.
Yeah, what part of Ohio?
Cleveland.
Cleveland, at the Cleveland Clinic. The clinic, as it's known. And I met Vahid at Rothman. You were the fellow signing out under Jerry Williams, who's a shoulder specialist there, pretty well known. And
never heard of him.
when you start fellowship, you kind of have to figure out how things are going to go. And you were the guy telling me that, so I hold you very deep in my heart, and because you really helped me out with some tips. Yeah. So how are you? How are things going here at the at the shoulder meeting?
Very good. First of all, thank you for having me. I also remember I have fond memories of fellowship that year. I think everybody who have done fellowship knows that year is a special. You kind of carefree, not thinking about anything in the world. Obviously, usual stuff, but this doesn't get repeated in your career, that you can focus on honing your skills. And I think that's a special year.
Carefree other than intense focus on shoulder surgery.
So it is like, maybe it's understated to say how stressful at times some of those moments can be, because you don't want to disappoint people you're respecting. These are your mentors, people that you're going to call your mentors for the rest of your career. A lot of tension in that respect, but maybe not having any clue of how that the care is delivered, and you all are focused on what is in front of you, and you don't know what you're attending or the whole running a practice means, and you're kind of thrown in this narrow area of come to the OR and see. You're almost like a tourist. So like, wow, you're excited about everything, but then your attending is who essentially
the director. They're directing the whole show,
directing the ship, and you're kind of vacationing on it for a year.
It's like, oh, the view's nice on this boat. Oh, this is cool. Wow, this is easy. You're on a boat. You're sailing out.
Absolutely. Yeah. I don't know where we're going.
Why you guys seem like you're doing so much work over there? Yeah, but that changes quickly, doesn't it?
It does. Yeah. When you start your practice and now you become the captain of the ship and I think also the bonds and friendships that you make because of the uniqueness of that year. Also, we carry, and we're lucky that we just keep seeing same group of people that we trained with, connected through education all throughout. I think that's a special part of this meeting for me, is like to meet up with my mentors and more co-fellows. This is our special first time our class of fellowship was able to meet up in one place.
Oh,
so
great.
This is the first AOS that we were able to after 7 years.
Yeah, I thought I saw all the guys here.
Exactly. Yeah. 7 years we get together, and it was like a special moment.
Yeah, it's pretty great too. Just I felt pretty close to you guys, and I felt pretty close to the class below. And because I got such a good sign out. It sounds basic, but you really helped really guide just that start, because first impressions become very important. Yeah. You want to be the guy that shows up and does hopefully the right thing, but at least you're trying to do the right thing, right? Because we all get better along the course of the year.
Absolutely. I mean, sometimes when you're getting trained, you're in the trenches, those kind of emphasis of this a step or do it my way seems excessive. But then when you become, the captain of your own ship, and you realize you have to somehow control this process. And the checkpoint for you is the person who I'm handing my patient to has done their homework and knows at least what I do. I wouldn't expect them to have the skills of a experienced surgeon, but then making that putting the work, or it's not just the work, it's kind of sense of responsibility.
Sure.
That you can build that trust over the years, that I think you could go deeper and deeper in education. You kind of open up, you talk about your mistakes, and you want that relationship to build. And the first step of that is you do your, utmost effort to, emulate your, the surgeon you're doing. So that's why that oh, I do it this way becomes important, not because I'm, dogmatic about my way of doing, because I want you to be in sync with me. So that's where that's coming from, I think.
Sure. Yeah, it's that communication that you have. And there's something about training and seeing and learning from real role models that are managing complex problems and simple problems, but in ways that are predictable, and they can have the most predictable outcomes because they care, and I think training at such a great center like that, you have these role models where even if you don't have that confidence, you see, you kind of embody their confidence. And then over time, you get it through fellowship, you come out and then you have this, like, probably a large amount of confidence to a certain extent. And then that gets humbling real quick during practice. And then you go back to all of those little secrets and details that you're like, oh, okay, that one case, that's probably why it didn't work out for this case. So the next one, you can learn something, because I think the first 1, maybe even 2 years of clinical practice is an extended year of training and learning just on the job.
I agree. I think probably I extended it because you have to make a lot of mistakes at least once to know what actually works in your hands, because what you have experienced in fellowship a lot of times is to fragments or pieces of the surgery that you get really good at, but putting the whole recipe together happens in your practice. And what we don't realize is that we kind of like a part of a technique from one surgeon, and we like the other part from another surgeon. And there's this assumption that you're gonna mix these two recipes together, and he's gonna make the the cake that you want. But
right.
Some of that happens early in the practice, is like, I did this part of Jerry Williams' approach with this part of Ramsey and this part of Laz, and when putting it all together, although you believe to those being the right way of doing it, you have to still make it work. Mm-hmm. So I think that finding your identity, and probably is a good advice to not experiment too much. So meaning that I think that's always
good advice, or at least maybe just change one thing at a time.
Absolutely.
Don't change too many things at once.
Absolutely.
Right? Yeah.
And early on, especially till you got your basics on, but basic skills on. And I think one other element is that when you start your practice, you really are at the most disadvantage. You work with the people at late hours. You don't have your team every day. You don't really have the support that your attending have. And a lot of times, the magic that the hands of a surgeon does comes at the kind of very right bed of all those people doing the right thing, having the right retractors, preparing the patient for the OR. So you're working so hard in setting that system up that the actual surgery, if you start doing too much deviation from what you have learned,
smooth symphony.
Exactly. It becomes, you want to get your bearings under and then start potentially experimenting or deviating. So my advice to my, fellows is pick one arthroplasty system, minimize the variability. And another factor is reps, find a good rep for yourself, that's going to be available. And those plays into your outcome early on. And after 2-3 years, when you have, you're comfortable, then you can start deviating. But doing too much changes early on is not advisable.
Laz used to say, trust the process.
Exactly.
Trust the process.
Don't go change my, recipe right away.
Yeah. Trust the process.
Absolutely.
I think that holds true. What were, when I was in fellowship, I had all these grand ideas about how I was going to change the world and change the field of shoulder surgery in different ways, and how can I kind of make my mark and fit in different ways. And you get in, and you kind of get through fellowship, and you're learning how to be a competent surgeon. But these kind of you can't help but see where things maybe could be better. Maybe either through implants or patient selection or the types of procedures we're doing, but then you get into practice, and then you continue to see the same problems and maybe different problems. Have you changed or altered your view of what you think is important in terms of progress in shoulder surgery now that you're out in actual practice in the big boy world?
You're saying surgeons having opinion about how things should be. So that's I've never heard of that. So
because let's
obviously-
just say you were an opinionated figure in fellowship.
I mean, it's-
That's why I ask you this question.
I see.
Doctor.
Okay. This is, angled
There
toward
may
me.
have been a comprehensive shoulder theory that was kind of talked about, whispered amongst the ranks.
So I'm not going to talk about that, but, because.
But that concept, I think, you have this like real big concept that somebody who's young and budding and it's like, hey, you haven't been kind of jaded to a certain extent by outcomes, let's say, and like maybe there's something there, right? Like maybe there's something there with having these like concepts of function that may be different than the common knowledge.
Obviously, I'm still early on in my career, and what I would say,
early, but let's say established.
You're
established.
7 year in my practice. So, and what I think the innovation, I've tried to study this. I'm, halfway through my business school, and actually, this is one of the topics that I'm really interested to understand better. Like, likes of Joe Ioannidis and Christian Gerber's, and when you kind of hone into how these people accomplished it, I think a big portion of that was these people gave themselves the permission to think different. Because a lot of times, like, when we're kind of in this mode of this is the way it is, this is the way we're thinking about
you don't think outside the box.
Yeah, you almost like this, do not give yourself the permission of thinking about something totally outside the box and contrary. So I think giving yourself as a surgeon that permission, you run in the risk of kind of coming up with crazy ideas. But I think as long as you're kind of grounded and don't go like invent surgeries based on your ideas that you came up by yourself, I think it's a healthy dose of that is very important.
Yeah, I've done that before. It's like, let's try this out in the lab. It's like, that's kind of crazy. We're not going to do that one.
So I would say this is actually an exciting era in shoulder, because
very exciting time.
Although, like, it seems like there's a lot of solutions, but it seems nobody really figured out what the right way of doing arthroplasty, that being the monolateralization, should we be doing this implant or that implant? These are very lively conversations in our society, and I think we're lucky that we're in this stream of ideas. And I think as young people, kind of not getting bogged down in the way of thinking and trying to kind of keep an open mind, I think it's very good. So last night we were kind of in our circle talking about, subscapula sparing. Mm-hmm. And I see that some of my colleagues are so passionate about this. Mm-hmm. And what I want to kind of do is to be a good listener when I see somebody is passionate about something, because, your reaction might be, oh, I've thought differently, or why this is important. But I see the passion in their voice and in their way of kind of thinking, expressing, which gets me excited. It might not be something that I want to do, but I think we
start thinking about it.
Yeah, as surgeons, like, I think we get, set in our ways, and anything outside of that seems wrong. And I think we should try to have some open mind. And again, when it comes down to treating patients, you don't want to go experiment too much. A little bit of experimentation is good in controlled environment. You said it.
Yeah, for progress. You need that for progress.
But I think a lot of it starts with, I like the ideas that is connected to different way of thinking about, like, for instance, like you can think about why rotator cuff tears in a biologic, sense, that, cells are degenerating. There's some biologic process that leads to a tendon degenerate and ends up to tearing. So if you are thinking about this as a biologic problem, you're gonna, your solution for this would be, how can I change that biologic process? Coming up with the medications, like, that, solves that problem. But then you can have a total different approach and say, this is a biomechanical problem. So, like, is the tendon is in disadvantaged, like, state, and that tendon, has to overwork and compare to another tendon, and that's why tearing. So then your solution for that starts with how can I change the mechanical environment of a tendon? And I think about these things a lot because as surgeons, we're in this mode of fixing a broken anatomy. And sometimes we really don't think why it was broken the first time. So somebody comes and says, oh, I like had an MRI, I have shoulder pain, and you look and you have a tendon tear. We as surgeons tend to say, I got to go back to put that tendon where it came from. So
and a lot of times that's the right thing to do.
It's the right thing to do. But in the context of a lot of like diseases, for instance, ACL tear. So for a long time, we fixed ACLs without paying attention to
how they were occurring.
Tibia plateau,
the angles.
So and then we found out that if you fix a ACL without like fixing the angle of the tibia plateau, it's going to recur. So those are the type of thinkings that I think we need in our field more. Is that when I'm looking at a B2 glenoid, is it only putting an implant to fix that missing bone is the solution, or there's something fundamentally changed in that shoulder that I need to pay attention as a surgeon, reconstructive surgeon, or someone that's coming up with ideas in terms of implant design to fix that problem that needs to pay attention. Is it a scapula problem? Is it a muscle imbalance problem?
Muscle imbalance.
Is it, the patient's like kyphosis? And so I think
contributing factors.
More of those thinking we bring to solutions we come up with, we will be more comprehensive. Is like, just pushing the head back where it was solves everything. Or, now this shoulder is subjected to a totally different biomechanical environment that I need to take that into account in my reconstruction. So hopefully, it's like, you talked about, these theories that, potentially you can tie up some of these events in a sensible way that you can think differently about them. So obviously, hypotheses, you have to come up with experiments, prove them. Hopefully, I'm in the process of creating those studies and do that. But
to make a meaningful impact and have some meaningful work.
And I think as the lesson for an innovator, for someone that wants to change the way we do things in the future, is that we need to change the way we think about problems first and realize what problems our solutions are solving, and then move into, I think sometimes we just jump into coming up with solutions. So I can't claim that I have all the answers, figured out any of these processes, but I like to think about them a little bit at a deeper level. And these type of meetings, think about collective thinking, bouncing some of these ideas with smart people that around us. It's the way to go.
Definitely. Yeah. I just had Andy Green on the show, and we were talking about the natural history of arthritis. He's publishing a paper on that. Yes. Just understanding arthritis, how that progresses over the course of 15
that type
years.
Of studies are so important.
So valuable. How many shoulder replacements have gone in since Nir was here?
Exactly.
And we're doing a study now on how shoulder arthritis progresses. I mean,
absolutely.
We got to look into
these. Very smart.
Very a thought leader.
Cerebral.
Yeah.
I think we need more.
We need guys like him and like you.
Absolutely.
These out of the box thinkers.
And Andy is amazing. So. Yeah. I think
to have the energy to go do those studies too.
That's the problem, is that those are not Me Too studies. Like, for instance, I've been trying to do this study of finding what the role of the scapula is, but it's very hard. Yeah. You don't really have a standing CT scan. So I've gone through,
and there's functional differences, positional differences. One thing I've really learned from personal trainers, fitness guys, is the role of your lower trap. It's like these muscles will have really important function for different types of functional force and different vectors of pushing. And you're just literally, it's like going back to kindergarten and learning how to, the alphabet, and then learning how to put the words together. We're learning how our bodies are operating and moving and then putting those things together to lift weights and do functional movements. We're orthopedic surgeons, but we don't really have training in functional movement and how your shoulder functions like physical therapists understands, or doctors. I've had interviews with doctors of physical therapy and personal trainers, and they have this whole different realm of understanding that definitely feeds into this comprehensive knowledge of what the shoulder really is. But we're the guys. Absolutely. Where the buck stops here with shoulder specialists, because we know the most.
Our treatments makes this equation, order of magnitude different, yet we think about this in the most rudimentary ways. So I was talking to, Ben Kibler. I think, Ben has done most work in, the scapula understanding.
Yeah, I know Ben.
And Ben was, giving me as an example of how simple we think about these things. And Ben's example for me was, what do you think the first muscle you attempt to raise your arm and from a standing position, what do you think the first muscle that fires in your body is? We all say
supraspinatus, right? Because that's what we learned in medical school.
Yeah, so that's the way of, okay, so I'm a shoulder surgeon, I'm going to focus on that. It's actually in your contralateral calf. Is the first muscle in your body fires when you want to raise your arm. So then it goes to tell you that when we're talking,
because you need something to push against, otherwise you just fall over.
It's like it kind of totally instantly changes the way you think about a problem that might, before you think about it in a shoulder, and now oh no, I understand why these balance what the role of all these rhythms in the muscles, and again,
because we're scientists and we're trying to unravel or reveal the truth behind what we're looking at.
Exactly.
Because
what is in front of you,
what's in front of me, and I'm trying to figure out what's going on.
Exactly.
Right. And then the more knowledge we have and the more data we have to make those decisions and identifying what the pathology is, so that when you do make the decision to treat, you're getting an accurate assessment of what they need.
Exactly. I think the lesson talking to these people who are, in my opinion, thinking a lot deeper is that they think about the principles that guide a normal structure before they think about the pathology.
A simple example would be scapular dyskinesia, right? Yeah. That's something you can see, and then there can be a lot of causes for that. You might have a nerve palsy. You probably have some kind of problem in your joint, and then everything's just not working right. And but if you can identify what the underlying cause of that you're seeing, that's what people are coming in to see us for. They want those answers, the correct answers, hopefully.
And there's absolutely no. That's a spot on, because scapula is like a black box for us. So and it's hard to study. There's a reason we know more about rotator cuff biomechanics, because it's a lot easier to study that. I do a lot of complex soft tissue reconstruction, muscle transfers in the shoulder, and when I started kind of doing this kind of stuff, I felt like I'm looking at this like a carpenter, this goes there, here, that goes here, I'm adding another force. And I was in this meeting, and Laurent Lafosse talked about a case that the reason this came up was this was actually a surgeon observing this, and it was very interested in why this was happening. This was a surgeon that his habit was in the dark room in the morning, without looking at his clock, being able to silence his clock in the morning. Mm-hmm. And he got a biceps tear, and he lost that ability. He's like, my biceps tore and my pain went away. I didn't have any pain, but I lost my ability of finding the clock in the morning in a special space that I had. Okay. So these type of stuff gets you to think about muscles just beyond the line of pull and force. They're proprioceptive devices. Yeah. And why all of a sudden you connect a muscle to a bone and the instability goes away, not because this is simple math of adding a force from the front, the top, and the back, because all of a sudden, you gave the body the ability, the proprioception for knowing where the joint is, which is, I see cuff to arthropathy as an analogy of a Charcot joint, because with no muscles attached to the end of the humerus, that's why some of these like cuff to arthropathies look like a Charcot process. So
and that's probably why they progress,
right.
and they just live with it for year after year.
And then how much of the acromial stress fracture in a cuff to arthropathy is coming from the body not knowing where to fire the scapula, and the scapula in a weird place, and it just overpowers like the acromion, and that's why it breaks in the cuff to arthropathy and doesn't break in a cuff intact patient. These are all hypotheses. We have to kind of test them, but we still, I think my core beef with the way we approach things usually is to let's jump into come up with a plate to fix the acromial stress fracture. But, how about, collectively we start thinking about like, whys, and, and that will put us at a different path in terms of innovation, research. And I think it should be, we all should be practicing more of deep thinking, I think.
That's a really good point. I think so too. One thing that really shifted my understanding was nutrition. My assessment of outcomes, how patients were doing with regards to their pain, and I just put it off as something that is too hard to study. And then Reza Jazayeri came on my show. He literally came on my podcast, and I learned about XR. And then, XR is one product, but it's an amino acid supplement that you give before and after surgery. And there's a few other products similar to that now, but they're standardized. I don't know if you use any supplement in your practice.
I know Reza's work, and that's a good example.
It's at least good enough to say, hey, let's look at nutrition. This is a major factor. And the more he looks into it, the more studies are coming out.
There's at least two abstract, around the role of nutrition.
There's something there.
Outcome,
no question.
For healing of the rotator cuff.
Healing and outcomes. I took it, I went through surgery myself. I had a rotator cuff tear doing jiu-jitsu, and I had to have a repair done.
This was recent?
It was a year ago. And then I retore it 4 months after.
Why, you didn't wear your sling? You started operating 2 weeks after surgery?
My surgeon said I'm a bad boy.
That's actually common as a surgeon, being a really bad patient.
I was the worst patient possible. And I thought I knew too much. And so, I retore it. So then I had to, thanks, but I learned. And my point is, I went through it myself. And when you go through it, there was somebody at a course, I think it was one of Frankel's course. And they said, if you have gone through surgery, you are an expert. Compared to a surgeon, you are almost the same level of understanding.
Yeah, very interesting. I had never heard of that quote.
And I never forgot that.
Yeah, you lived it.
You do live it. You learn it. I'm like, I've experienced it. I lived it myself. I know what it was like. And as a surgeon, that's an interesting thing to go through that yourself, that proprioception concept you were saying. You totally start understanding how your body works, and going back and thinking about how my shoulder was dysfunctional, and then seeing how I was able to basically eventually do the right thing, rehab correctly, and things healed great, full strength, I went back to competitive
just
jiu-jitsu.
Explain that to me, right? Why was that tendon important? Why,
super important, and it really has helped me talk to my patients about what's important. And I say, and if they ever kind of quiver on, I say, look, I went through this myself, and this is why I'm telling you. And I do it because I care, and that's the right thing to do. We tell our patients, but a lot of it's based on experience with outcomes, with what we've trained on, and how people are doing, right? Our experience. But that was a pretty powerful experience for me to go through that.
Yeah, I can only imagine. It's like going through surgery, something that you talk with your patients on a daily basis. Now it's like, it's relevant. I have to do
it's relevant.
I have to live it. Relevant. Absolutely.
Luckily, it wasn't a replacement or anything. And so I was going to ask you too, in terms of what do you think is the future of shoulder? I know we have these really cool concepts. There's so much cool stuff now, especially with AI. But where do you think things will be in 2 years, 10 years? We're at the cutting edge of what we're doing. We've seen so much progress in shoulder, even since fellowship, but it hasn't been there's a new surgery we just do now. We haven't seen anything like that. We've seen advances, right? Tendon transfers, how to do them better. But what do you think is going to be a major shift, or are there going to be any major shifts? How do you think the future looks?
I don't know. I'm qualified to answer that question.
Well, you're the most innovative, one of the most innovative people I know. You got your finger on the pulse.
So
besides you designing the stuff that we're going to be using.
That's true. I think some of this innovation that we're going to see comes through industry driven.
Has to be a part of it. Yeah.
Innovation. And with, I work with industry, and I think the incentives there are to definitely, come up with better ways of doing things, being more efficient. But there is a utilitarian kind of approach in that type of innovations, that what we can make money out of.
It's got to work. It's got to be useful.
Is this the 2025 model? Is that different than 2022? So, there's a different type of innovation that comes through those channels. I think the future hopefully will be through, I see a wave of, responsible use of AI in, through platforms like Complexity or Grok or deep thinking, that potentially is going to give us better ability of looking at the data, looking at patterns of behavior, patterns of motion, which we're not even thinking about. That we'll have a camera, a patient walks in, and we'll have them do different motions, and you feed the CT scan, X-ray. So I think there are things that we're not even in the horizon for us, that things like AI is going to make possible, which I think a deeper look at the research. So I think our research and data has been very rudimentary, analyzed by stats that it's based on p-value. But when you have intelligent machines, surfing through, sifting,
you can be more discerning. Get rid of the stuff that's not good.
Yeah,
find the good data.
Core, what is finding nodes of innovation. So I think right now our, as I said, drivers of innovation are, can you sell a product? Can you find a market for it? But are those the only, drivers that we should be paying attention to?
Right. Probably not.
Yeah. I mean, listen to likes of Christian Gerber, he would say in the past 30 years, none of our innovation has led to betterment. I think Mattson had a series, and these are very, people who have lived and advanced this field, talking about how we should be responsible in terms of directions we're taking our future. So I might not have answered, added any useful information to your question, but I think again, in the same theme that I like to speak about, how we should approach our research questions and our innovation, I would say future is going. I'm more excited to see what we haven't seen yet in the future. I think arthroplasty, guidance, things like, works that Bossum is doing in muscle transfer. Those are very exciting, but I'm more exciting, the new fields that's going to be created by AI.
I think so too. Yeah. AI is going to be interesting and kind of tell us, but we are responsible for the future. We're the ones that are going to be paving the way. And it's people in this room, the conference center, this meeting, for sure.
Room, yes, of course.
Yeah. Well, this room too, definitely. And it's a really interesting concept to see, where things will go, but, things happen because that's what the world does. And, hopefully we can make a useful mark, in it, to help some people.
It's very exciting. I'm very excited about the future.
Yeah, me too. Well, it's been really good talking with you, man. Is there a website? Do you have a website that people could find you if they want to get a referral to see you? I know you're a busy academic surgeon. I
would love to. I have my Cleveland Clinic, website.
At Cleveland Clinic, they can find you, right?
Yes, absolutely. And this was really enjoyable. Thank you.
This was fun.
I didn't know what to expect, but this is very fun.
That's a show.
Very spontaneous, and actually, I enjoyed chatting with you.
Yeah, you too, absolutely, man. I'm really glad we could take some time and hash some things out.
Absolutely.
Yeah, Vahid. All right, buddy. Absolutely. That's it. That's all, folks.
Thank you.